awful lot of information. We didn't have an awful lot of information about what what the outcomes were. So it sounded good to us at the time. By the end of today, you will understand why it doesn't sound so good anymore. So if we do this, it's on us this time. So Governor Lamont is exploring returning to MCOs to run the Husky program. We created nohuskymcos.org to inform Connecticut about what's at stake if MCOs come back to Husky. DSS has hired consultants. Oh, sorry about that. To look at the idea, and also they've broadened it to look at other options for Medicaid and what we could do to improve it. And so that's sort of where we are in terms of the status. And so I'm going to talk about what happened before when we had it and why they ended, what the evidence is, and what you can do about it. So what are Medicaid MCOs? Medicaid is Connecticut's state program that provides healthcare coverage to low-income families, individuals, seniors, and people with disabilities. MCOs are managed care organizations. These are private insurers that run Medicaid programs. About 45 states use MCOs to run their Medicaid programs. MCOs are paid a flat per person fee per month or per quarter to cover all the necessary care for their members. If the costs of the care are lower than the state's payments, they get to keep the money. If they're higher, they lose money, and that's also called capitation. There are two ways for MCOs to make money. They can do that by keeping people healthy, so keep you out of the emergency room, out of the hospital, so you don't need more expensive care, or they can just deny needed care. Currently, Connecticut runs our Medicaid program without MCOs. We pay providers directly for the care that they give members without middlemen. Great. So what happened when we did have MCOs? Connecticut, the Governor Rowland first hired MCOs to run Connecticut Medicaid in 1996, which is when I joined the state. A state study found that in the subsequent 16 years, found that 4 out of 10 providers listed by the MCOs did not take MCO patients. Enrollment in MCOs was regularly suspended because they didn't have enough providers to care for members. An audit found that the MCOs were overpaid by millions of dollars. That's actually eventually what turned the tide, and legislators wanted to get rid of them. Connecticut's doctors, the Medical Society, was suing the MCOs for engaging in deceptive and improper practices that harmed patients. And this was the bane of my existence when I staffed the Medicaid Oversight Council. We could never get data from them. We actually had good contracts, but you couldn't enforce them because we couldn't get accountable data. We were always hearing about apples and oranges in the whole fruit orchard. It was incredibly frustrating. In 2012, one of the first things he did when he came into office, Governor Malloy ended the MCO contracts and moved to our successful care coordination model that we have now. So looking at the evidence now, since then, there's a lot of evidence, been well studied. And despite many years and many studies, there is no evidence that Medicaid MCOs improve access to care or the quality of care that members receive. And that's according to MACPAC, the Federal Medicaid Oversight Agency, but also I did a lit review. It's painful, but you go through the haystack to find the needles. And I'll talk about one really important paper that you find, but you really can't find any evidence that of sustained quality improvement or savings. They don't save money. Connecticut has saved billions of taxpayer dollars since 2012 when we ended MCOs in Husky. That's not Ellen Andrews saying that, that's DSS saying that. Connecticut's cost control is now the best in the nation. We spend 2.75% of program costs on administration compared to the US average. That's almost 3 times that, or I guess 3 times that. Compared to other states, this is really important. Connecticut spends 7.7% less of our state budget on Medicaid. This frees up $4 billion with a B dollars in funding for other priorities, things like public health, other kinds of healthcare, housing, education, whatever. If we brought back MCOs, and that's just the average state, we would be spending 4 billion more out of our budget. Despite many years and many studies, there is no evidence that they save money, and the inefficiencies, just a few of them are listed there. Things like advertising. You have to have more than one MCO in each area, and so they compete with each other. They pay taxes. MCOs pay federal taxes. Since we don't have MCOs, that is not a burden on our taxpayers. Their administrative costs, the data reporting, anyway, it goes on, and profits as well. Our Husky per member costs are, what is going on here? Are stable. You can see they flip around a bit at that last part where I put the circle in, and this is DSS's graph, but you can see enrollment is going up, but our per member per month costs are pretty stable. Other states can't say that. This came from the Kaiser Family Foundation, formerly known as now KFF. If you look up their areas, their list of innovation areas for Medicaid programs, you'll see that Connecticut, again, my red circles, is the only state that is listed in every single one of those 8 or 10 different areas. So when you'll hear from people that you have to have MCOs to innovate. In fact, we're more innovative because we don't have to go through middlemen. And these are delivery reforms, delivery of care reforms, payment reform models. There are 5 that KFF looks at. We've implemented 4 of them. And as soon as we have the maternity bundles in Medicaid, we will have all 5. So this is the needle in the haystack I found in one of the lit reviews I did. This was a study. It was published in January by an oncologist in his team at Wayne State University in Indiana, and he has had a lot of trouble getting care for his patients with cancer in the Medicaid program that he doesn't have on the commercial side. And so he just wanted to see, is there any states that don't have it, and can I compare to someplace comparable that does have it? And so he found Connecticut as a natural experiment, and he compared us to New Jersey, which is socio-demographically matched. And he looked at, this is just the early stage change in early stage diagnoses over time. And you can see from 2007 to 2012, we were pretty well matched. And then after 2012, when we got rid of MCOs, our diagnoses went up significantly, up 4%. And even more interestingly, survival rose 8%. So this isn't just about money. This isn't just about administrative burden and inconvenience for people. This is about lives, people's lives. So Governor has a great question. It's a fair question. Why do most states use MCOs for Medicaid? So I called around to people I know who run Medicaid programs, both with and without, the few that still run them without. And I never got the answer that it saves money. Nobody honestly believes that. It is easier. States with MCOs outsource a lot of their administration and complaints from the state to the MCOs. There are some states where hiring more state employees to do that is just not a political option, so they don't have a choice. It does give some predictability to budgets, that it really, with 1 million people in the program, our budgets are pretty predictable. Even the deficit we're looking at right now was predicted. But there's still the most variance happens when, depending on who's enrolled, and that MCOs have no control over that. It can be very hard to move large bureaucracies from MCOs contracts back to direct program management. We learned that in the 12 years it took to move them, to get rid of them. And some states their Medicaid programs are really in bad shape. They don't have many people, they don't have many providers, they're not paying well. And so MCOs can actually improve the quality and access to care. That is not the case for Connecticut. We have actually one of the better programs in the country. And it's important to note that most large employers, including our state employee plan, don't use capitated MCOs for cost and quality reasons. They used to, and they did away with it. So Husky members have actually a lot to lose. Husky is now in the top quarter of states In 17 of 28 adult quality measures that the Center on Medicare and Medicaid Services tracks, and 13 out of 22 child quality measures. I talked about cancer detection and survival. It will be harder to get appointments for care, and there will be fewer providers accepting Medicaid patients at all. When we did away with MCOs, we got a bump in a year of 33% more physicians. This was from the Medical Society, came back into the program to participate. There'll be more administrative hurdles to get the care that people need, more delays. Right now, Medicaid is one of the faster payers, but it was routine that they would wait a year or more to pay when it went through the MCOs. And there'll be less access to independent reviews, to reverse denials. Prior auth rates among the MCOs are among the highest of any payer. You may lose coordination of care through a primary care provider and through intensive care management. We don't know what the future of those programs would be. And people may not be told about better but more expensive care options because that money comes directly out of their capitated rates. And these problems would fall hardest on seniors, people with disabilities, and communities of color. And this will increase health disparities. What would it mean for providers? Long-awaited payment rate increases that the state has been working on together with consultants and legislators. Everyone's pretty on board that we need to look at these rates, and increases are likely to be needed. But that'll be at risk because providers will have to now negotiate payment rates with their MCOs. There'll be likely more prior authorizations and denials, as well as delayed payments. The administrative burden of submitting claims to multiple MCOs. When we started, we had 14 MCOs. Just everybody who worked in a provider office was just, massaging their temples. And when I talked to them, and as providers leave the program, and they will, there'll be more demand for care to those who stay. We're going to also lose a lot of opportunities. There's a lot happening in Connecticut to bringing stakeholders around a table collaboratively. I don't know about all of you, but I'm on a bunch of them, to try and work out answers to problems that pretty much everyone has identified. And these are just a few, but we're working to improve primary care and connect people to community services, to increase those low payment rates, to increase access to care, expanding access to mental health and substance use care, and to support justice-involved members to improve their lives and maybe, stop readmissions to prisons. Connecticut is designing these programs and can implement them directly. With MCOs, we would have, if we designed something or we had an idea we wanted to do, we'd have to go to the MCOs and negotiate with them to implement it and probably pay them more. And then any profits from the savings generated by those programs, all of our efforts would stay with the MCOs, wouldn't come back to the program. So I think I'm really on time. So we are arguing that Connecticut should not bring MCOs back into Husky because it could lower quality, it costs more, lost opportunities for improvement, fewer providers available, there'll be more denied care and more administration. And if you want to know more, you can go to knohuskymcos.org for more information and to keep updated. So I would love to hear what you all think, unless, how do I stop sharing? Here we go. There. And cancel that. I would love to hear questions and thoughts anybody has.
Thank you, Ellen. I believe, let me see. It looks like everybody is muted. I think we have a security setting on that. If you have questions and you want to put them in the chat, that would be, I think that's the best way to proceed. I will begin by putting a message in the chat.
I may have buzzed through that a little too quickly.
It was a lot of information to process, but very, very useful.
Thank you.
So I'll start with a question. In Connecticut's experience with MCOs in the past, the capitation model concerns me because there are, for instance, um, disabled folks who are high utilizers of medical care or long-term care. And something that I observed in my work in New York was that sometimes it seemed as though the MCOs would sort of do their best to push out high utilizers to send them to the other plan in their area. Is is that something that
Yeah,
was the experience in this state? Can
it
you speak to
absolutely
the
was.
concerns about okay.
Yeah, there were concerns that not only pushing people away, but also cherry picking. There were, and you know, these were stories from people that I believe from providers that a uh, for instance, a van would show up for one of these MCOs outside of a provider facility and offer free blood pressure checks and other kinds of, you know, questions about your health. And if you were healthy, they'd work real hard to sign you up for their plan. If you weren't, they'd say, oh, well, you know, you should take care of yourself. Good luck with that. Yes, there were even stories at one point about gifts being given out, and I know it happened in other states. People given microwaves, for instance, to sign
Wow.
up. Yes, and there are ways to also with a skinny plan, a skinny provider panel to keep people out. For instance, if you don't have, say, an HIV center, you're, you know, there's the state-of-the-art HIV center in your community, but you don't sign a contract with them, people with those, you know, with that condition are less likely to show up. So yeah, there was a lot of cherry picking. I see a ton of questions here. Let me see. Is there a draft email we can use to contact the governor? There isn't, but I will put one in the tools section in nohuskymcos.org. What can we do to prevent MCOs? Well, that's a great question. I think right now, contacting the governor, we're going to be contacting legislators and just calling them and saying, this is a bad idea. If you have questions about advocacy, we also have an advocacy toolbox on our main cthealthpolicy.org. If you right on the top when you go there, there's an advocacy toolbox that'll help you if you want to write a letter, if you want to testify someday, whatever you want to do, there should be a page for it. Let's see, middlemen too often add no value and raise costs dramatically. You are going in the right direction. Thank you, Don. Yes, that's very true. Very rarely is it makes sense to add another, as my husband put it, another hand in the till. Don't really see how that's going to help. The state budget situation about Medicaid, yes, that reportedly, I have no inside knowledge, is there is a deficit, and that's because they didn't, it was foreseen, but they didn't add money to the budget to get to a balanced budget. And I know that the Republican caucus, at least one Republican caucus is asking the Attorney General to look into it. So that wasn't really that we overspent, it's that we didn't, I mean, we did know what it was going to cost. We just didn't change the budget. Let's see, somebody primarily works in behavioral health, and though most codes, CPT codes, do not require pre-authorizations, the ones that do are treated very fairly, and authorizations are dispensed in a timely and predictable manner. We would hate to see this end. Yes, we would all hate to see that end.
Yeah.
Is the Healthy CT program adding to the Medicaid budget situation? If you mean covered Connecticut, I think that is a separate program. Okay, that's a separate program that is part of the health. It is and it isn't. I guess there were cuts to Husky program, about 12,000, I think. Husky parents at slightly, you know, none of these people are wealthy, but slightly higher incomes were cut off the program. They're supposed to shift over to covered CT, but that's not, that was part of the budget. That was included in the budget. So that wasn't the reason for the deficit, if that was the question. Was this what was used when Husky for Kids, when that program started? When it became Husky, yes, The Rowland administration rebranded it because of the Yukon Huskies. So yes, that's what we had when it was branded the Husky. But Connecticut has had Medicaid since the 60s, like most states actually. So this is a program that's been around a long time. It's built for exactly the people that are in it. And we have, I'm not going to tell you it is perfect. I will never say that. And every year, I'm part of some of the advocates who try to add to the program or fix problems in the program. And that's why all of us are around those tables, and hopefully you are too. I know the Office of Healthcare Advocate, who does a phenomenal job. You're very lucky to have this Lunch and Learn in this office to help navigate this nightmare of a system. But Medicaid is, and probably providers are underfunded, but it's still much, much better than it is in other states. And it's much, much better than it was under the managed care, when we had managed care organizations. I used to get calls all the time at the Capitol, people asking for, my doctor isn't taking me anymore. I can't find anything. I'm not getting what I need. I don't even know who to talk to. I wait for hours online. That doesn't happen anymore. It's not that things are perfect, but also through the council, DSS is much more responsive because they have to be. They can't just look over, to the HMOs and say, so what are you doing about it? And they say, humana, 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 and nothing happens. So I just can't, I'm having PTSD even thinking about going back to that. I hope that answered some questions. Did I miss any? I don't know. Adam, did I miss any?
I no, that's the last question that I see. But thank you for all of this information and for your experience, your long experience, working on this problem. We do have a few more minutes. We can take another question or two. We can.
I would love to know if anybody has experience having worked in other states that have MCOs, or maybe some of you were here when we had them.
Yeah, I'd be curious as well to hear from providers who had the experience of working under the MCOs versus the care managed Husky program versus how they feel about commercial insurance now relative to it. Because in at least in New York, when I was working there, it was commercial insurers for the most part who ran the managed care and managed long-term care programs in Medicaid.
Yeah, I think it still is. And I know there's quite a few people in New York has actually asked Sheldon Todman and I both worked on this and have invited us, legislators included, to come talk to them about our program and how they maybe could learn from this.
Mm.
And actually other states have as well. I think just recently Minnesota and Hawaii, and I'm forgetting the states that we've talked to, but it is, yeah, it's an interest. If the governor makes this change, will it impact the Quimby program? To be honest, I'm not sure, Lois. That's outside my range. I do know that the governor has been concerned about long-term services and supports costs, and I think the Quimby program would be affected, especially if that's going to be the focus of this. They were thinking about only getting MCOs for the long-term services and supports and not having the rest of the population in, but I was really surprised when I spoke to them about that, because I said, I don't think there's any states that do just long-term services and supports. And most of them that even have managed care for long-term services and supports, it is often, when it's done well, it is run by the providers, the long-term services and supports providers, who then take on financial risk. These are pretty new and there isn't a lot of information about it. And it's a really scary thing as a provider, if any of you work for providers, it's a scary thing to take on risk, especially for the most fragile of the most fragile. And Dawn says the proliferation of PBMs and other vendors like Prudent RX are causing significant delays in care and reduced access to care, particularly in oncology. You run the Connecticut Oncology Association, and I would love to talk more. Anybody who wants to get in touch with me, at the bottom of every page on all our websites, there's a web form. If you just put it in, I'll get that. Someone's saying when I worked in our local hospital, when the state used the MCOs, it was very difficult with some populations to determine who their MCO was. Yes, I remember this. If there was a language barrier or if the patient was compromised, we had no central place to search for coverage. Yeah, that is a massive problem. And and then figuring out how to bill for them. And a lot of times people had inaccurate information. People, I remember, were defaulted into plans if they didn't choose. And sometimes that was into a particular plan. I think it was Oxford, now United in the beginning. In different places, they were put into different ones. And then they tried also rotating it through. And it really made your head hurt to keep track of all the different administrative changes. It was really, really hard to track. Yeah, and it wasn't surprising that providers said, I want to do this, I care about this, but I can't deal with all this administration. We actually found a lot of providers who said, I'm still seeing my same patients, I just can't bill for it. I'm just not going to get paid for it, which is also not sustainable. On that cheery note, I think we're out of time.
I think we are. We were just joined by Representative Wood, who may have wanted to participate in this conversation. I've asked her to unmute. If you don't mind staying on for another minute.
No, that's fine.
Well, either it's not unmuting her or maybe I'm putting her on the spot, which I also don't want to do.
She's very, very good at expressing her concerns and thoughts, and I appreciate her time coming today.
Oh.
Hi, Representative Wood. I think you can talk now. There you are.
Hi.
How are you?
I'm good. How's it going?
Good. Got lots of very good questions on the concept of MCOs and Husky coming back. Mostly, but I don't think anybody's a fan of it, and concerns about how it worked last time and whether it be as bad again this time.
Great. I literally just jumped on. So did I miss the whole presentation?
Yes, you did.
Unfortunately,
okay.
Yes.
Okay.
I'll give you a call. You get a special just for you presentation.
Thank goodness. I prefer a special one-on-one with Ellen. So no, I just tried to jump on. I spent 20 minutes trying to connect to the internet, so I apologize. But obviously, something that I really wanted to hear you, Ellen. But looking forward to definitely learning more about this. And I'm just reading, about it in the paper and over the emails and stuff I'm getting. So I have a lot to learn.
Well, great. Thank you. And as co-chair of insurance, this will definitely come to your desk. So I'm grateful. Thank you. And very grateful to Adam and everybody at OHA. This has been, I love being able to talk to you all because you all know where you're, I don't have to start at the beginning. You all are already at a good point of understanding. And it sounds like many of you lived through this last time and don't want to do it again. So thanks very much.
All right. I think with that, I will end this Zoom call. But thank you all for coming. And please get in touch with our office if you have questions about health insurance denials, enrollment issues, eligibility, all of the many, many ways that our healthcare system can confuse and frustrate you. We're here to help you. Thank you. Have a good day.
Thank you. Bye-bye.